before I continue with my discussion of the COVID-19 understanding of our Filipino or the COVID-19 experiences of Filipinos, I'd like first for us to situate our understanding of disease, health, and illnesses. So to do this, I'd like to introduce several concepts. The first one is that of disease. Disease is something that we already know. Most of you are medical scientists, and so you are very much aware what is a disease. And in Filipino, we call it sakit. So you have the biological, medical symptom associated with this. Now, I would like to go further in our discourse of that and go to a different context or a different understanding of disease, and that is the same spelling but different pronunciation, and that is sakit. So disease is sakit, illness is sakit. And what is this concept of illness? Illness is something that we use as a term that we use in the social sciences to refer to the social, cultural, political, economic reasons or environment that make a disease bearable or aggravated within a population. In short po, ito po yung mga factors, context that make a disease difficult for a population or less difficult for a population. And so we have to demarcate those boundaries of disease and illness. And there's another concept that I'd like to bring in, and that is the concept of sickness. Now, what is sickness as opposed to disease, as opposed to illness? So sickness would be the expressions of the symptoms of a disease. Now, in Filipino, how do I transpose this? I believe a good translation could be may sakit. So it's sakit, sakit, may sakit. Now, when we talk about the concept of being may sakit, most of the time we have to understand that diseases greatly affect one sector of the population. In my work on HIV, I've looked into how certain sectors of our population are more vulnerable to HIV than other groups of people. In the same way, in our current status right now with the COVID-19 pandemic, we are very much aware that certain sectors of the population are more vulnerable to the disease. I think at this point po, alam na natin sino yung mga sector na yon. We are told that it's going to be the older population, those with comorbidities, and then lately it's been shifting into younger population. And I'd like to discuss that a little bit more later. Why is the demographic of people who are getting sick shifting from older adults? Now it's shifting to, let's say, the younger, the working class, the working age group. So the concept of sakit, disease, must be understood within the social context, the social framework of a society, hence making it more of an illness experience. And then the symptoms that are being displayed could also be understood within a social context. I've highlighted here a paper that focuses on one population that is calling for, scientists are calling for greater attention for them because they are highly vulnerable to COVID more than other members of the population. The link is right here should you want to revisit it. Now, another word from this root word of sakit that I'd like to bring into the table is the concept of Pasaket. Earlier in the prayer, it was the community pantry was mentioned. I'll be discussing a bit of that in a while. Why is there a public clamor during this time of pandemic? How are we understanding now COVID-19? Is it just a medical condition for us now? I think at this point it's utterly clear that it is beyond the medical now, that it has transcended the social, it has transcended even the religious context of our lives. So I'd like to bring into the table the concept of Pasaket. And what is Pasaket? Pasaket, for me, at least in this understanding of social health, Pasaket would refer to the suffering that is induced by a particular medical condition, a social suffering that is induced by a medical condition. I think for most of us who have been watching the news nonstop, we are all going to agree that the pandemic has opened up this can of worms about our healthcare system, about our government, that there are so much gaps, there are so much inequalities that have made groups of population highly vulnerable, and those that are just surviving before are also made vulnerable now. So the life choices of people are highly structured by racism, sexism, political violence, and grinding poverty. One of my pet peeves of recent time is when people use the word pasaway. I totally hate that part. When people say that Filipinos are pasaway, the masses are pasaway, they don't follow protocols because they're pasaway. These people have a gap in understanding why people still go out to the streets, why people get to violate some health protocols. They do not understand the lived experiences of these people. And this afternoon, I'll be sharing some bits of that. I'd like to share with you all how I've seen this among the community members that I've been working with. Why is it so hard to follow simple rules that the IATF have given for us? Now, in a project that I've completed last year, no, sorry, we're trapped, right, in the pandemic, so that's not last year. 2 years ago, before the pandemic happened, I got a grant from World Health Organization in collaboration with DOH and PhilHealth to understand what are the Filipino social values to the concept of healthcare access. Would they want to pay for health related issues? And so to do that, I did a national study of this, and this is one part of that project. We're in the lived experiences of achieving well-being among Filipinos are determined by three major factors. One is the socio-cultural challenges, systemic challenges, economic challenges. Since I don't have much time today, I'll focus first on the socio-cultural challenges. For the socio-cultural challenges, what makes it difficult for a Filipino to go to a hospital, get some help for a medical condition? There are three parts to this issue. One is kin-based health decision making. I don't know if you would agree, because maybe you're not the sector that is represented by this study, but have you ever experienced it that your decision for your own health must be decided by the entire family? So this is something that is so real for the people who participated in this study. Like, if you have, let's say, if you get sick, what do? Do you just say, all right, I'm sick, I have to go to the hospital? In most cases, you have to tell first the members of your household. You have to tell them that, okay, I'm sick, and what do we do? It's a family decision for the most part. What hospital you go to, how much you're willing to spend, how are you going to manage this condition. All of this are so kin-based. And we are noticing this as well during this time of the pandemic. Most of the people that I've spoken with who turned positive did not initially get themselves checked. Why? They were afraid of the economic repercussion to their households. If I get sick, if I go get tested, that means I have to ask money from my family members. I have to take money from my family's income, something to that effect. So the decision to seek help, to be treated, all of those are done within a household context. Next is stigma and community-based knowledge of the disease. This is where it gets so hard to address the COVID-19 pandemic. Why? Our community response to the disease is to immediately stigmatize the person who has symptoms of this. I live in a condominium, and so if I get to be inside an elevator and then somebody coughs, immediately the people within that elevator get so worried that maybe this person has COVID, and so everybody is in a panic mode. Imagine that kind of stigma, that you're not allowed to cough anymore, you're not allowed to display any kind of symptom associated with COVID-19. And imagine imagine the number of people who did not report their cases because of the stigma that they will lose their jobs, that they would be ostracized in their villages. This is a real experience of this country during this pandemic. Next is that of the marginalizing personal characteristics. In most cases, access to health becomes a decision that is based on, am I a person that will be highly marginalized if I get this kind of disease? For example, people who are gender marginalized, and they catch, let's say, diseases that are related to that are sexually transmitted. Immediately, it's so hard to seek help, because people would immediately profile you already, that, oh, because of your gender orientation, then that must be the reason that you got this. So the stigma again comes in, and at the same time you're already marginalized. So it's layers and layers of difficulty to address a particular disease. For this time of the pandemic, one thing that I've seen is that the fear of COVID rests among the upper class up until the lower middle class. Those who are within the poverty to urban to below poverty, they have, sure, they're aware that this is happening, sure that they are a bit scared about this, but the need to survive, the need to address their daily needs, or the food, specifically food, the need of their family for food trumps all types of fear that is associated with COVID. So that being said, we immediately associate that the lack of health, what do you call this? The lack of safety precautions on this matter is highly associated among the urban poor or those within the poverty lines. And this has implications to our public health decision-making points. Okay, so in focus, so I've just provided a frame of analysis for us today. Now, I'd like to focus on 5 parts of our response to this pandemic. One is enhanced community quarantine. Second is social distancing. Third is washing hands. Fourth is balanced nutrition. And fifth would be vaccine in terms of equity and attitude. These are just most of you, I don't know how many of you have already been vaccinated. I keep on whining to our group, sa group po namin ni Dr. Sin. Ang joke ko ay, isa ako sa mga nag-evaluate ng vaccine pero hindi pa ako nabavaccinate. Why? Because I'm not part of the priority group, and at the same time, I am also what do you call this? We also have a gap in the supply of vaccine. So I'd like to discuss more about that in a while. Let me just focus now on enhanced community quarantine. Just last year, well, over a year now, we declared our first enhanced community quarantine. No public transportation. All older adults and children were not allowed to go out. Every family can only have one person going out. We had those barangay passes and whatnot. And how did this affect the Filipinos? How did this affect regular Filipinos, the working class Filipinos? It affected us in terms of, number one, the disrupted economy. Since I've been working with urban poor communities, what I've noticed is that they were highly affected as well. How? The delivery of supplies like this one that you're seeing on your screen, this picture of a child and a lola trying to peel garlic cloves, that's one of the key income sources in Pasaket compound where I've worked for 10 years. And because of the pandemic, the suppliers of garlic cannot enter their barangay because they're an urban poor community. They were immediately locked down because they said that COVID will be highly transmissible in these areas. So without this source of income, which is only, by the way, 70 pesos per day, for one family, 70 pesos per day. I'd like us to remember that context. Because of this, they cannot get their 70 pesos per day. Hence, it immediately translates into food insecurity. Immediate translation to food insecurity. And this does not only translate to households being food insecure. Hindi lang po yung, ang dissertation ko po kasi ay tungkol sa mga nakakatanda po na nagugutuman sa Baseco. Ito po ang natitira, si Nanay Inday, siya na lang po ang natitira sa lahat ng key informants ko, lahat po sila namatay na. Si Nanay Inday po ay nag-aalaga ng 4 na apo na iniwan sa kanya ng anak niya. Hindi niya na alam nasaan yung anak niya. So, at the age of 70, ilang taon na ba si Nanay? 75 ngayon. Siya po ay active na economic provider ng 4 niyang apo. Paano mabubuhay si Nanay Inday during this time of ECQ na bawal na siyang pumunta sa Divisoria? That's one thing that I was so adamantly fighting this government for. Why did we stop the older adults if we cannot provide for them? Si Nanay Inday po ay isang maggugulay. Hindi po yung nagtitinda ng gulay ha. Si Nanay Inday po, siya po yung pupunta sa Divisoria. Alam niyo po yung mga gulay na hindi binili, tas tinatapon na lang. Si Nanay Inday po, pinupulot niya yon, tapos pinuputol-putol niya, yung retaso ang tawag po nila. So Nanay Inday creates those retaso, sells them so that she could feed and raise her 4 grandchildren. But because of the ECQ, because of this pandemic, because of the limitation for older adults like her, she was not able to feed her grandchildren. Yung nakikita niyo po dito, ito po yung food intervention na ginawa namin for several months until nawala na po kami ng resources. Another key population affected by the ECQ are single parents. There is a grave this is a grave issue that we are not addressing. A lot of single parents don't have household help, and because of that, they are stuck with their children. They cannot go out to do grocery. They cannot go out to do their regular work. Why? Because the children will be left at home without anybody helping them. So they cannot bring their children outside as well. So this is another gap in policy making. And then I'd like to emphasize that in food insecurity, even those who were not initially food insecure became food insecure during this time. Example, the jeepney drivers that we have lining up along UP area, lining up everywhere in Quezon City that we see. Second policy that became problematic, and that is the initially we called it social distancing, right? And then until social scientists said, don't call it social distancing, it's just physical distancing. So, physical distancing. Easy for people like you and I to follow because we have our own spaces. But how about people like them? Ito na yon. Ito na po yung sinasabi nila ng una. Yang mga Filipino na yan, pasaway yan. Tignan nyo, ba't nandiyan yan sa kalye, pumipilang ganyan? Why? Because they needed work. They needed work so that they could get their food to their family. These people are not pasaway by choice. They are there because of structural gaps in our society. In Baseco compound where I work, ito po yung Baseco compound. Di ko po alam kung ilan na po sa inyo nakapunta sa Baseco compound. Siyempre po pag nandyan po ako, wala po akong makeup. So, dito po sa Baseco compound, ito po ay reclamation area. Wala po yan dati. Kung naalala niyo po, ito po yung port area. Tapos po nung panahon po ng Marcos, binili po nila tong port area, di marami pong dayo na dumating. Pagdating ng mga dayo, naglagay sila ng stilt houses. They started with that. Until they started building this area to the point that it became more like an island of some sort. So naging solid na area po yan. That's 52 hectares and about 70,000 individuals live here. So it's a very compact congregate setting. Now, when you say physical distancing, when you say isolation, when you say that people should maintain space, how did we imagine that for the rest of the Filipino people? Because we did not. In Baseco, a typical floor size area would be about 10 to 20 square meter. 10 to 20 square meter, one household with 5 to 7 members. How are we supposed to initiate concept of isolation, concept of distancing? We can't do that. Hence, when one person catches the disease, everybody catches it, at least in that particular area. Third point, personal hygiene, washing of hands. Nako, ito yung favorite lagi na nila sabihin, di ba po? Wash your hands, wash your hands. Ang dali sabihin ng wash your hands dahil marami po sa atin, we have potable water. In Baseco po, water is very expensive. Ito pong nakikita nyo na picture na to, yan po yung unang balon na pinagawa ko sa area na yan. Pagdating ko po dito sa Baseco, yung mga bata, punong-puno po sila ng galis. Tinanong ko, bakit kayo, ano ba nangyayari dyan? So, bibigyan ko sila ng gamot. Na-realize ko, it's because they don't wash their bodies enough. Why? Because water is very scarce. So, they don't have access to basic needs such as water. So, ano pong nangyayari? Sa Baseco po, merong ganito. Pila ng mga balde. So, ano po sila, parang may 5 gripo lang po sa area na to. Tapos, pipila po sila and bawat lalagyanan po na yan ay nasa 7 to 10 pesos. 7 to 10 pesos po yung isang lalagyan. Remember po how much they earn on a day for a regular family? About 70 to 100 pesos. If you're gonna buy, let's say, several of these to take shower, to wash your clothes, you're not gonna have enough money for food. And that's the reason why hygiene is a problem. Not because they don't want to take a bath, but because there's no enough resources for it. And so sometime last year, pinagpilitan talaga namin to, naghanap na ako ng mga donors. We asked for the building of, I don't know the right term, may mga engineers pa naman tayo. Yung pagkabit po ng gripo, so the connection of the water faucet, ito po yun. For the first time in 25 years that these people are living here, they have their own faucet. The women are organizing so that they have their own faucet. So, why is this very important? Because washing hands, that rule is so hard to follow in Baseco because water is very expensive. And then there were water interruptions as well from Maynilad. And so all of this make following the protocols so difficult. Next, sabi nila, just have balanced nutrition and you're gonna survive COVID. Sure, that's easy to follow. Until you're from the margins of this society. And then the government would say, but we give you ayuda. And this is a typical ayuda. This is an actual photo from the field. This is the typical ayuda that they got. And they got this several times during the first implementation of ECQ. Imagine eating sardines every day. Are you gonna get balanced nutrition for that? And the answer is, of course, a no. Ano pong ginawa ng mga collaborators ko sa Baseco? Alam niyo po yung Baseco kasi, pinagigitnaan po siya ng Manila Bay and Pasig River. So, estuarial community po to, estuary. So, ano pong ginawa nila? They went to the water to get seafood. Is it good? Nakakuha po sila ng crabs, shells, hipon. So, pinagayabang pa nila sa akin, pinicturean nila, sinan nila sa akin na sabi nila, Doc, tignan nyo, meron kami mga alimango. Pero po mataas po yung lead content nun. Dahil nga Pasig River ito and that. So, yung toxin level po nun mataas. But they would rather eat that because there's no other food that they can put their hands on except this supply. So, we also have a crisis on what kind of food are being delivered to the margins of our society. And this is where I think I'd like to discuss this point. The community pantries. Na-mention na po kanina ni Doc yung community pantries na sana hindi ma-red tag and sana mag-continue. First question as a social scientist that we have to ask is, why did it happen? Why did community pantries come about? And immediately the response to that is because we have what you call as structural gaps in the society. Nag-implement uli ng ayuda. It's been a year-long lockdown for most of us, a year-long of not having work for some people. And so this strict implementation again of the lockdown created economic stress that cannot be addressed anymore within the household. And so since the ayuda did not come on time, the ayuda did not suffice, community decided to have their own action. So a structural gap bridged by community action. But then again, and this is a very unpopular opinion, and it's coming from me, and I already got so many hate messages because of this. I've been asking organizers to please be mindful of your implementation of your intervention. Why? The lines in Maginhawa, I don't know kung ilan po sa inyo nakatira sa Maginhawa area, but the lines there are reaching 500 meters and so forth. And a friend of mine who's a doctor who lives there has taken pictures and such and said that it's 1 meter distancing and such. Are we pasaway? Of course, the answer is no. But we're sure that we're hungry. We're sure that the government has not sufficiently addressed our needs. But is this the best response for this particular issue? And this is where I'd like to bring in again our concept of illness. We're in the disease, we know what the disease is already, but the social conditions make us tweak, make us reinvent, make us revise our understanding of the threat of the disease. The people falling in line as early as 3 a.m. for these community pantries have already removed in their head the major threat of COVID-19 to their own health and to the health of the family to whom they will go home to. The organizers are well-meaning. Most of them are my friends. They're well-meaning, but they have also probably they weighed the risk and benefit, and they saw that feeding people right now would be higher of a benefit than the risk of them catching COVID. And this is what we call as a localized understanding of diseases. Now, is this going to help us with our fight against the pandemic? My clear response is a no. Me and several other public health friends of mine are saying that place will be a breeding ground for another surge, and we cannot afford that. The temporary solution is riskier than what it poses for the daily benefit. So how do we go forward with this? I provided several suggestions, and just for the sake of mentioning here, the point that we're trying to say there to them was that you have to divide the resources, send it to the communities, because there are reports that people from Rizal, as far as Rizal, would go to Maginhawa just to get the supplies. Why not cut the resources in Maginhawa and send it to Rizal and let the community there deal and create their own community pantries? This will be the same idea of providing support, but also understanding that there is the threat of COVID. So let's go now to vaccine hesitancy. Don't worry, I'm down to my last 3 slides. So vaccine hesitancy. As mentioned earlier, I am part of the Health Technology Assessment Council of the Philippines under the working with the Department of Health. Now, what we do as a unit is that when there are health technology, or when we say health technologies, this involves medicine, any form of intervention that the government will pay for, it goes to the Health Technology Council. So what happened is that prior to the evaluation of the vaccines, what we did was conduct something that is very akin to social sciences, and that is to conduct stakeholder consultations. And with this, we use the method of focus group discussions. We did not have the luxury of time to do interviews or a nationwide survey and such, and another unit of DOH was doing that anyway. So what we had to do was consult key populations, key stakeholders on what do they understand about the vaccines, what do they want about the vaccines, and their predisposition towards it. You can read the result of that FGD through this link that I've posted in the slide. But this is something that I've captured, and this is from the participants, the community leaders from high-risk areas. Noted when we asked them, what do they prefer about the vaccines? Please note that we did not ask them like, do you want Sinovac? Do you want Pfizer? We did not ask them that. What we asked them was, what characteristics of a vaccine would be highly important for you? So they imagine these are community leaders, all right? They're not scientists. They're not oriented towards how we understand vaccines. So we were very surprised that the first thing they said was, we hope that it went through clinical trials. They did not use the word clinical trials per se, but they use words like na-test yan. Na-test yan ng mga scientists. You know, stuff like that. So they understood the concept of clinical trials and such. And then notice that they were not so much underscoring the concept of brands, right? They were not about the brands. They were more about was it tested? Did FDA approve it? Those were the main considerations that they have. Although, side note, and it was in the report anyway, there was one vaccine that they said if given the choice, they would not want to take that particular brand of a vaccine. So that was part of the discussion. Now, for you, as scientists, what was your major consideration for getting a vaccine? I'm not so sure how many of you have gotten vaccinated already, but what decisions did you have, or what considerations did you have when you went for the vaccines? For the Health Technology Assessment Council, what we usually do in all of our evaluations would be to ask these two primary questions. So ito po yung social science side ng health technology assessment. We usually ask this particular question, does the health technology, so papalitan lang po namin yung term na yan, does this technology possess the characteristics desired by key stakeholders? So this one is for Sinovac. And the result of our evaluation is that, yes, based on the short-term outcomes, the Sinovac is acceptable for the population, the general population that was part of the inquiry. But and the second question that we asked is about equity. Does this vaccine reduce or not further add to existing inequities in the health system? Favorite kong part ito sa tinatanong namin kasi nung dinidevise pa po namin itong, when we were still devising this parameters, I asked our chair, Dr. Marita Reyes, do we really want to say this, that reduce or not further add? And she said yes, because we recognize that our health system has inequities in it. We're not removing that reality. So I love that part because that is already a good start for any health council to recognize that there is inequity in the system, and to say that we hope that our decision will not further it. That is already a good start. So regarding this particular context, is it going to produce inequity? And our answer is not necessarily. Why? Because we said this vaccine, the logistics needed for this vaccine is not as heavy as, let's say, comparing it to, let's say, Pfizer. Yung Pfizer na vaccine po, that was high, that was going to promote a lot of inequity because places like GIDA, geographically isolated and disadvantaged areas, mahihirapan po tayong i-transfer yung Pfizer na vaccine to those areas because of the temperature requirements of that vaccine. Compare that to, let's say, Sinovac, that does not require that much. So when we do our evaluations, one of the things that we consider relating to the social sciences, apart from the cost, Dr. Aleli Kraft is also part of the council. She does all the economic side while I do the social side. For the social side, one of the key considerations is will it make some groups more vulnerable? And to do this, we look at the Progress Plus, which is an acronym to put together all contexts like uh, geography, gender, a whole lot more in one package. So we hope that by looking into every single detail, are women more vulnerable if we allow this particular health technology? If we say yes, then we lower the score for that. So regarding vaccines, how are Filipinos feeling about the vaccines? An anecdote. I had to convince my parents to get vaccinated. They're both frontliners and not medical frontliners, but they're both frontliners and they're both seniors. And I told them, please go be vaccinated. And the thing is that most of them, no, sorry, both of them, not most, both of them were very worried about vaccination because they said that there's just conflicting statements, being given in the media and such. And this is not an isolated case because this is how a lot of Filipinos feel about the vaccines. Are we reaching our target vaccination? If we had supplies, do you think we are going to reach our target vaccination rate? And the answer may be maybe not. Why? Because in a recent survey, we are not so sure about the extent of validity of this, but in a recent survey of Pulse Asia, they mentioned that 6 out of 10 Filipinos didn't want to get vaccinated. Just a few days ago, I received a call from a community leader from Caloocan, and he was saying, Doc, hindi ko naintindihan ano yung nakalista dito sa papel. Ano po ibig sabihin ng immunodeficiency? And I was so caught off guard. I asked him, why do you have that? Hindi po ba yan nakatagalog? Ang sabi niya, nakatagalog naman po lahat, pero yung mga condition, naka-English lahat, hindi namin maintindihan. And I asked them, what are they doing right now? So apparently, they gathered together, hence no physical distancing. They gathered together, called me so that I could explain to them point by point what does it mean to be, what does comorbidities mean and such things. And so I immediately messaged our council and said, there's a problem with our communication. We have poor communication science. We are not relaying our information properly to the public. Yes, maybe we are giving information well to people who will understand, but how about those who are within the margins and they consist majority of our population? So that's one issue why we're not getting vaccinated. First is that there's a gap in understanding the mechanics of the vaccination. When you ask a regular Filipino, they don't understand. By regular, I'm sorry that I'm using the word regular. What I'm trying to say is that if you ask any member of the public about vaccination, they don't have a clear grasp of what is a vaccine. That's number one. Number two, how is this gonna affect my life? How is this gonna affect our society? All of those, there's a gap to that. And another thing is that it's so hard to register for vaccination. Have you tried registering for vaccination? It's hard if you're not technologically adept. Imagine community members. And of course, DOH would say, sa community members po, sa mga birth nila to ginagawa, may paper. Pero po, most community members are already they're already plagued by previous issues of our healthcare system. I'm gonna mention Dengvaxia. So that already affected their feelings towards vaccines. And now you want them to get vaccinated by something that is so unknown and you want them to go to a center. So mahirap po. And this creates gap in our want of vaccinating our population. So those being said, how are Filipinos experiencing the pandemic? We're all Filipinos here. Most of you have lived through a whole lot more social issues than I have. We are all aware that this pandemic has totally unraveled the issues of our country, from poor leadership to poor health systems, that we know if we don't address it right now, we are not going to survive another pandemic. And the worst part of that is that the inequity of is just so high. We are surviving. We can order our food online. We are all safe within our spaces talking about this. But the rest of the Filipino people are not safe. The rest of the Filipino people don't know where they're going to get their food tomorrow. Thank you for the invitation again, and I hope for more discussion.